Welcome to the Association of Women Endoscopists Endoscopic Mucosal Resection Center right here. We have an international expert. I'm so delighted to have Dr. Uzma Siddiqui from the University of Chicago to show us her tricks and tips of the EMR. Thank you for being here.
Thanks, Mary Lee, for having me, and it's a pleasure to be part of this course again this year. And I am thrilled to talk about one of my favorite procedures, which is EMR, endoscopic mucosal resection. If you guys want to see these tips in writing, I did publish an article on my top tips and tricks in GIE last year in April. But you know, when you're doing an EMR, there's a couple basic steps that everyone should follow. The first thing is a really nice inspection. Now, obviously this is a pig stomach and we're kind of making our own polyps, but you want to assess, okay, what's the size of the polyp? Where am I in the colon? Does it go over multiple folds? What is my scope position? How stable am I? Because all of these are going to go into your mind. How am I going to plan to resect this lesion? So this one, we'll say this lesion's maybe 15 millimeters or so, and it does go over a fold, so maybe it'll be a little bit tricky to inject it. If I'm looking at a polyp that is going over a fold, I tend to inject proximally to bring it towards me. If it's a really humongous polyp that's over 3-4 centimeters, I just tend to start at the distal margin, inject, and then I start cutting right to left out of habit. And then I'll work my way towards the more proximal edges and keep injecting and resecting from there.
Uzma, any tips and tricks on how to enhance the margins? Any endoscopic chromoendoscopy?
So I don't use staining in terms of chromoendoscopy. I'll usually use whatever digital
Vice or MBI.
Yeah, exactly, to just look at the borders. But that's where your injectate solution comes into play. You know, I always use something that has dye. Every endoscopist has their preference. I'm sure you and I maybe use different mixtures. But when you're doing your submucosal injection, if it has dye in it, that's probably your best bet for defining your margins. There has been some data that says if you mark the borders, even in a colon EMR, that perhaps you'll have less residual polyp on the surveillance, but as a rule, I don't tend to do that much, and I'll just inject with a dye in my solution. But that gets us to, after you've done your careful inspection, you have a management plan, then you get to your equipment. So I do have a distal attachment cap on my scope. That's going to help with position stabilization. If there's vessels, I can help isolate those. Also, if it's a really flat polyp, we were just demonstrating this a little bit earlier, you can kind of suction in the tissue while you're passing your devices to create a little bit more of a pseudo lift to help you grab that with a snare. And then you're gonna, decide what kind of submucosal injectate you're gonna use and what kind of snares you're gonna use. Now when I inject, usually, and everyone differs on this too, but I inject, put the needle deep, and then I pull back and inject.
So you do a dynamic injection to bring the lesion towards you?
Yep.
Okay.
And, again, there's debate. Should I go on the side of the lesion or, behind it, in it? This is a small lesion, so again, if I know it's benign, I'm not worried about any kind of tumor seeding or anything, I'll just go right in the middle of it and just lift it all up at once. I try to keep all my devices very close to the tip of my scope, and rather than push out devices, I want to get close to it, because then you have more control over what you're doing. So now we're going to put the needle out, and then we're going to, so I'll push in, and then I'll start moving once we start injecting. And so we're seeing, in the pig stomach, sometimes it can be a little bit harder. Yeah. But you want to see, and then you can lift up a little bit, like we were talking about the dynamic injection. Needle back. And then once I have seen a nice separation of the submucosa from the base, then I'm going to start going with my snare. Now, I also sometimes like to put my lesion underwater in addition to injecting. And, we talked about on our virtual panel with Ken Bin Moeller, because historically everyone talks about underwater EMR. Is one of the benefits is that you don't have to do a submucosal injection, but for me, why not do both? You're using every tool, right? Because I want to get off the muscle layer, give myself a little protective cushion, and then I want to use the water also to help make the wall a little more lax and allow the mucosa to go into my snare.
And I like the dye because it helps demarcate the margins clearly.
So why not use everything? So
I agree.
I do both.
I agree.
I cannot do both on this because I don't have water, but for my injection, for my submersion. So now, if we talk about equipment and snares, the bottom line is there's hundreds of snares out there, but you want a stiff snare. So my preferred snare is a very stiff monofilament snare, and then I never use a snare over 15 millimeters.
I was just going to ask that.
So if you're doing a huge EMR, the only thing you're going to gain by using a large 30 millimeter snare is a perforation. So I know if it's going to come off in a couple pieces already, what's the point of increasing the risk of my procedure? So I like a 15 millimeter snare. Again, I'm a creature of habit to avoid mistakes. I always keep, again, my catheter close to the tip of the scope, and then I always open above it. We'll open here. This is a 15 millimeter snare. And then I like to, you know, again, normally I would submerge the lesion in water, and then I put it over it. And then your goal always, you want to tip down because you need something for the tissue, the snare to grab. But then while your assistant is closing, I'm also closing. I'm trying to push the base of the catheter on the snare towards the base of the polyp. Hold on one second. Okay, go ahead and start closing. And you see I'm kind of pushing down.
Any special tricks on how you communicate with your assistant?
Yeah, so usually what I'll say, okay, start closing, closing, and as I'm saying that, I'm pushing out, and then they always say, oh, it's tight. I'll say a little extra. Because in theory, if I know I'm not going to cold snare through this and just chop it off, so if you go a little tighter, in theory, you're pushing the muscularis out of the snare, hopefully. It's not foolproof, but you know, perhaps preventing a perforation. So now we have a good piece of tissue, and then I usually I have an Irby generator, so I use an endo cut setting, just because you get a little bit cleaner margin. If there's going to be a little immediate bleeding, we'll take care of it. There has been randomized studies where they've looked at coag versus cut, really no difference in outcome, so it's kind of up to your preference. And then I always say that a big EMR is like putting a puzzle together. So once I get one piece, then I know where I can put my snare open. Say if you want to take off the edge of this, open. You know you can kind of set it into this edge, and then you can take off your next piece. So, and then, you know, you just make your way around till you take the whole polyp out. But once you've done your resection, you're not finished. You got to look at your resection base. Are there any visible vessels you want to cauterize? Do I want to soft coagulate my edges to prevent recurrence, which is something I usually do routinely. And then I'm going to decide, am I going to close this or not? So if it's feasible and I can do it in a relatively quick time, I probably would try to close, especially in the right side of the colon, lesions that are more than 2 centimeters. But oftentimes the polyps we take out are humongous. So you're just not able to close them. So I'll just coagulate whatever vessels I see, and then use some sort of hemostatic powder or gel, although no data to show that that prevents delayed bleeding, but it makes me feel better, so I do.
Well, thank you very much,
All right.
Uzma, for your tips and
Good luck
tricks
with your
of
EMRs. Take care.
Okay.